Now, after about 9 months or so, he started getting recurrent symptoms, which is like loss of consciousness and gradually he was unable to walk, that is inability to walk. He came to a hospital. Now that he reached Chennai, he came to a hospital. He underwent complete neurological assessment, and his MRI brain showed multiple infarcts on both sides of the brain, and the CT angiogram showed a multivessel disease. The multivessel disease means the brain has got 4 blood vessels, 2 in the front, what is called a carotid artery, 2 in the back, what we call a vertebral arteries. Again, I'll show you the picture shortly. And he had a very high grade stenosis of all the 4 blood vessels. That means at any time he could stroke majorly and he will even lose his life. This is one side of the picture which shows the right side of the carotid artery, which shows very, very high grade stenosis. How do we get around this? Obviously, we need to increase the blood supply to the brain. So, what we thought we should do for this patient, as we always do for other high-risk patients, is removing this block under local anesthesia. Giving full anesthesia will put him at a great risk, not only for the system, like he's already suffering from hypertension and asthma, also to his brain. And we will not be able to assess his flow to the brain if he's under anesthesia. So, what we did was, this is a routine practice, we gave anesthesia locally. We block the nerves which go to this area so that the whole area becomes numb. What is called a regional anesthesia. You are all familiar with the spinal anesthesia, where you give an injection to the back, the leg becomes anesthetic. Similarly, you block the small nerves which goes to this area. This is called a regional anesthesia. And we have planned, that is the incision area, that is the block we have given. We keep talking to the patient so that we will know the blood is getting enough blood supply. So we do this, and we clear up this block. This block is nothing but what we call a fatty plaque or atherosclerosis, which we see quite commonly in the heart, leading on to the heart attack. That is why this is also called a brain attack, because this happens to the brain. And we remove this block and we close it up. Patient did extremely recovered very well. It made a smooth recovery, and nearly about 4 months now he has done extremely well. Now I'll give a small background about this procedure and the stroke, etc. What is a stroke? When the blood supply to the brain is cut off suddenly, the brain suffers. The brain cells or neurons suffers. And it depends on which part of the brain suffers, you get the symptoms. The reason for the sudden cessation of blood supply may be due to a blockage, what we call a thrombotic stroke, or it may be due to hemorrhage. The incidence of blockage is higher and the incidence of hemorrhage is lesser. Just getting to the statistics, every 3.1 minutes someone around the world is dying of a stroke. The stroke incidence anybody above 55 years, the risk of stroke keeps doubling up. Nearly 72% of all strokes occur in people above the age of 65. Obviously, we are talking about somebody who is elderly, intervention anyway. That is why we should be careful in doing these procedures. What happens if we get a stroke? 10% of the stroke survivors recover completely, 25% recover with very minor impairment, 40% experience moderate to severe impairment requiring some amount of additional care, and 10% require extremely high care which requires rehabilitation. Unfortunately, 15% of them die immediately after stroke. So, stroke not only causes disability and about 15% causes death. What about the health economics? You should be looking at it. It costs about 73.7 billion in US. This is an estimate from 2010. And in US, for each patient, it's about 140,000 US dollars per year. So it is a very, very, not only for the country or the government as such. The stroke, it doesn't discriminate. It affects all kinds of people, all ages. Even though we say it's a disease of the elderly, it can affect the younger people also. It affects all kinds of ethnic groups with all kinds of backgrounds. Mind you, most strokes are preventable. So if we can take enough steps, we can reduce the incidence of stroke. This we talked about earlier. 85% of the stroke is due to thrombotic or ischemic, and 15% is due to hemorrhage. Within the occlusion, that is a thrombotic stroke, there is a small amount what is called embolic stroke, which comes from the heart. And the majority is from the blood vessel going to the brain, what we saw. patients which can undergo this procedure and a stroke can be prevented. As I said earlier, the symptoms depends on which part, front of the brain, it can be back of the brain, it can be side of the brain which takes care of the movement, so patient have a disability, the brain which takes care of the speech, you lose your speech. As I mentioned earlier, there are 4 fibrils at the back. So, the severe carotid stenosis results in severe hemodynamic imbalance, that is, blood flow is reduced. So, patient can develop either global hypoperfusion or a stroke. So, what happens if you have a plaque? As I showed you the picture, the fatty plaque in the origin of the blood vessel. A small thrombus can form, and this thrombus can be taken. It depends on the size of the clot which is taken to the brain. Now, I want to introduce a terminology what is called a TIA. It's called a transient ischemic attack. Majority of the patients having this small block in the blood vessel going to the brain give a warning symptom, what's called a transient ischemic attack. This is nothing but a minor symptom of a stroke. It can be a speech loss, it can be movement loss, and it can even be a visual loss. And if you can take care of this very, very carefully, and if you intervene at that stage, I think you can prevent a major stroke. What is transient ischemic attack? It's a very, very minor stroke which lasts for a few minutes or sometimes few hours. And when the blood supply to the brain is deprived of oxygen in the blood supply, and it wears off completely when the blood flow returns. And they do not result in a permanent brain damage. And that is why, it is too often it's ignored. So what is the importance of TIA? Can you ignore it? No, you cannot. Because 1/3 of the people can actually go on to develop a major stroke, which 5%, within a year 12%, within 2 years it's about 20%, within 3 years it's about 20%, 25%. So this is the warning sign. If you don't take care of it carefully, you will land up in a stroke. Because nobody knows that something else is coming up in future. Denial. Because a lot of people think, stroke cannot happen to me because I'm fit and well otherwise. And think nothing can be done. They think, okay, so what if I had this problem? There is no treatment for this. Actually, there is. And obviously, some of our patients do worry about the cost. In our center, as we do tend to look, and then you can go ahead and do an angiogram, which I showed you earlier. There is a blockage here. Here you can see almost 99% block here. And this patient deserves a surgery quite immediately. Otherwise, he developed a major stroke very shortly. And this is multiple pictures of the angiogram. Right. For those who are interested, what it actually looks inside. This is what actually looks inside a normal artery. This is what looks inside a bad artery. What we talk about, the atheroma, the plaque, and the rupture. These are all like intermediate type of plaques. This is what we call a high-risk plaque. And imagine when the blood is going through, small plaques can flip off and then go into the brain. As I said, depending on the size of the plaque which goes into the brain, size of your damage or disability increases. So this is one of the what we call in vitro studies which shows this picture. Transient ischemic attack. Can I do this after a stroke? We talked about some group of patients who recovers very well after stroke. Yes, to prevent another stroke, if the patient has got critical stenosis, we can't do it. And that's what the American Heart Association showed, that 60% of the patients who are recovered after a minor stroke develop a major stroke. So to prevent this attack, yes, we can do this. Why do we talk about this so-called the local anesthesia, regional anesthesia? It certainly reduces the morbidity because we avoid the general anesthesia completely. It gives me an opportunity to assess the blood supply going to the brain, what we call a neuro observation. It is also cutting down the cost to about almost 1/3. And of course, because I do it in the local anesthesia, patients who actually saw a lot of patients accepting to undergo this procedure, even though it's a major procedure, we will tell them it's done under local anesthesia. And again, we're giving a local anesthesia, blocking these nerves. We do this, and this is what which comes out of the artery. This is a huge plaque, and you see what called a crater or ulcer, and there's a thrombus sitting here, and this is what when goes into circulation to the brain causes a stroke. And bear with me for a few minutes. I'll just show you a small video clipping so that you'll all understand very clearly. This is actually the neck. This is the top end, this is the bottom end. This is obviously one. I think you need to understand the risk, what is going to cause a stroke. you need to understand the symptoms very, very early, and you need to respond to very quickly. As the introduction has been given earlier, there is a window period, there is a golden hour period. The window period somewhere maximum of 6 hours or so. You need to call 1066 ambulance to get in early. So, my dear friends, unless we intervene early, we are not going to prevent stroke. The patient can land up in a major disability or may lose a life, and for the family and for the healthcare providers, it is going to cost a lot of money to get them out of this trouble. Thank you so much.
Good afternoon, everyone. How many of you understood Dr. Balaji's presentation? Please raise your hands. I really want to know how many of you understood it. Good, I see that there's some medical people in the crowd. So, I think, understanding is a very important part of the process that the brain plays. The brain is only 3 pounds, but it is one of the most vital organs in your body. It acts as a computer, it is our human computer that processes everything that we see and what we hear and what we touch. And that's how important the brain is. For many years, and even at Apollo, we focused on the heart, because the heart is very important. We do understand that it's critical to life, but we must also understand that the brain is one of the most critical organs in the human body, and what this can mean for in terms of leading quality of life is also very important. So from what I understand, and there was so much that was said earlier. In fact, I told Suganti, I have to repeat what was said earlier. What shall I say that is different? But let's remember a few of these important things. The first is that every 20 seconds, someone around the world is getting a stroke. In India, 1.8 million people suffer from stroke. This is what we are trying to help. This is what we are trying to prevent. And I think more importantly, I would like to congratulate Dr. Balaji, because with the work that he's doing, the awake neurosurgical procedure called endocrinotomy, he's improving the quality of life. And to do that, it brings, you have to have skilled doctors like him. You need to have, the entire infrastructure support from the right technology. And I know that just yesterday for my own mother, we used a biplane lab. But technology is important. Clinical skills are important. Having the right management team and the team that looks after the patient post the surgical ward. The nurses, the doctors, and this is why Apollo is a success. I think we're able to bring together every aspect of patient care, from skill to technology to aftercare, to bring these wonderful clinical outcomes. And Dr. Balaji himself has done 700 surgeries, and we're coming to you after the 700th surgery just to show how successful we can be. And that at Apollo, it's really, the chance of failure is very, very low, because we can only look at what can make us a success. Dr. Balaji also spoke about symptoms, and this is we were just talking earlier, and he said in the US, people have over 65, they just have this checkup to make sure that these arteries are not getting colluded. In India, we wait for the symptoms to happen, and like he said, when the symptoms go away, we don't worry, because we think it's a one-time symptom that's come to us. But I think this is a very important learning for us. And Apollo has been talking so much about preventive healthcare. So let me promise you today that for every patient, for everyone who comes for a checkup over 60, and Venkat, you are here, that we will do this, because we have to make sure that the brain, which is such a critical organ, is functioning in perfect order. And so preventive checking before the symptom actually occurs, when a patient is symptomatic, is crucial to success, and I think this is what we do. We spoke about strokes. So I'd like to tell you some of the work that we've done in strokes. We've created an amazing ambulance network, which is, you just dial 1066 or just four numbers to get an ambulance. Within 10 minutes or maybe 15 minutes, the ambulance is with you. We use AI so that the image of the brain is quickly relayed to the surgeon and he knows what to do next. We believe that the golden hour is very critical for dealing with stroke patients and giving them quality outcomes. And we've done this. I think we've done this for 39 years over and over and over again. So you can imagine how good we are in this space of stroke and stroke management. But I would also say at this time that we're also good at the simple things. We're good for the headaches, we're good for the stomach aches, we're good for everything. And I think the importance of this is that at Apollo we understand that the whole human body is important, that we're all of it is connected in some through neurons, through the brain. There is a connectivity between every organ of the human body, and the brain is a processing center. So today you're here to really speak about something that's very important. I hope you will give it that importance. We did not bring the patient in front of you because we do want to maintain patient confidentiality, but we did more than save a life. We gave quality to that life. And I think it's more important than rather than giving years to your life, we give you quality to your life. But having said that, I'm sure you know that every 2 minutes of a stroke, we lose every minute of a stroke, we lose 2 million neurons. And we reduce our longevity by 3.6 years. So let's not lose even a minute. And for all of you in the press, please communicate this message. I think time is vital, and I think that greater understanding of what we're doing is very, very important. It's not just for old people, it's for the young as well. Let's start checking to make sure that they live a happy and healthy life. And I want to assure you that Apollo will be part of that journey, that we really do want to add quality to your life. I'd also like to thank Dr. Balaji for that wonderful presentation. And I know that he's been doing this for many, many years. It's just today that we decided to have a press conference so that people around us know that there's always hope for you. And trust us, we're there to look after you. Thank you very much.
எல்லோருக்கும் வணக்கம். கொஞ்சம் தமிழில் சொல்கிறாங்க. இப்போ நம்ம பார்த்து பேச போகிறது என்னன்னா, பக்கவாதத்தை தடுப்பது எப்படி, பக்கவாதத்தை ட்ரீட் பண்ணுறது எப்படின்னு இல்லை, தடுப்பது எப்படின்னு சொல்லிட்டு. தடுப்புறதுக்கும் வாய்ப்பு இருக்கு, அதுக்கு மெத்தடாலஜியும் இருக்கு. அதை பற்றி நம்ம பேசிக்கிட்டு இருக்கோம். இது எல்லாருக்கும் சொல்ல முடியாது. மேடம் சொன்ன மாதிரி ஹை ரிஸ்க் குரூப் பார்த்தீங்கன்னா, இந்த பக்கவாதம் யாருக்கு வருதுன்னு பார்த்தாக்கா நம்ம வயதானவங்களுக்கு வருது. அதான் ஹை ரிஸ்க் ஃபேக்டர் சொல்றாங்க. புகைப்பிடிக்கிறது, ரத்த கொதிப்பு இருக்கிறது, ரத்த கொழுப்பு, கொலஸ்ட்ரால் இருக்கிறது, சுகர் இருக்கிறவங்களுக்கு. இவங்கெல்லாம் மேடம் சொன்ன மாதிரி நம்ம ஸ்கிரீன் பண்ண ஆரம்பிச்சாக்கா நம்ம கண்டுபிடிப்போம். அப்போ நம்ம கழுத்துல இருக்கிற ரத்த குழா மூளைக்கு போது அதை நம்ம சிம்பிள் ஒரு அல்ட்ராசவுண்ட் டெஸ்ட் மாதிரி பண்ணி பார்த்துட்டு அதுல மாதிரி அடைப்பு இருந்தாக்கா அதை நம்ம கிளியர் பண்ணாக்கா ஸ்ட்ரோக் ப்ரிவென்ட் பண்ணலாம். இதுதான் சயின்ஸ். இது நம்ம வெளிநாட்டில் பண்ணீங்கன்னா இது ரொட்டீனா பண்றாங்க. இது எல்லாருக்கும். உதாரணத்துக்கு நீங்க செஸ்ட் செக் பண்றதுக்கு போறீங்க, ஹார்ட் பெயின் சொல்லிட்டு, அப்போ அவங்க பண்றாங்க. ஸோ இந்த மாதிரி பேஷண்ட்ஸ் எல்லாம் அதிகமாக நம்ம ஸ்கிரீன் பண்ணாக்கா கண்டுபிடிச்சி இது மூளைக்கு போற ரத்த குழாயில இருக்க பேசிக்கலி இது கொழுப்பு வச்சு அடைப்பு தான், அதை ஓப்பன் பண்ணி கிளியர் பண்றோம். இது முக்கியமா நம்ம என்ன கத்துக்க வேண்டியதுன்னா, ஒரு பேஷண்ட் நம்ம கிட்ட ஸ்ட்ரோக்கை தடுக்கிறதுக்கு வராது. இந்த ஆபரேஷன் பண்றதுக்கு ஒரு காம்ப்ளிகேஷனே ஸ்ட்ரோக் வரலாம். அதனால நீங்க உங்க டெக்னாலஜி டெக்னிக் ரிஸ்க் அண்ட் காம்ப்ளிகேஷன் கம்மியா இருந்தாதான் நீங்க இந்த ப்ரொசீஜரே பண்ண முடியும். நீங்க ப்ரொசீஜர் பண்ணிட்டு பேஷண்ட் ஸ்ட்ரோக் வந்தா அது பண்றதுல பிரயோஜனமே இல்லை. அதனால இந்த ப்ரொசீஜர் ரொம்ப ரொம்ப முக்கியம். நீங்க கரெக்டா பண்ணணும், பண்ணி நல்ல ரிசல்ட் தரணும், அப்பதான் பேஷண்ட்டுக்கு பெனிஃபிட் இருக்கும். ஸோ முக்கியமா பாத்தீங்கன்னா ஹை ரிஸ்க் பேஷண்ட்ஸை கண்டுபிடிக்கிறோம், ஸ்கிரீன் பண்றோம். அவங்களுக்கு இந்த ப்ரொசீஜர் வந்தாக்கா, இந்த ப்ரொசீஜர் பண்ணாக்கா இருக்கிறதுல ரொம்ப 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 கம்மியான காம்ப்ளிகேஷன்ல அவங்களுக்கு நல்ல ரிசல்ட் கொடுக்கணும். அதுதான் ரொம்ப முக்கியம் இந்த ப்ரொசீஜர்.
the way you explained the procedure, you made it sound as if it is a very common procedure that is done. But I'm also told that this is one of the first times that such a procedure is done here. So why is it so rare in India? That is my first question. And the second question is that would you classify what this particular patient experienced when he was in Bangalore as an episode of TIA, or he had prolonged symptoms after this?
Right, okay, we'll take these two questions into two parts. But number one, well, this is not a new procedure. Actually, this procedure was described 70 years ago. And initially, when it was described in US, this was very rampant. People started using it for everybody, started getting into complications. And then they went into hiding, literally. And then a lot of studies were, don't have that technology and technique, your results are not going to be good. So the patients are going to go back with stroke. So, you have to be very, very careful. In fact, when I came back from UK, there were a lot of resistance amongst patients. Why even neurologists were not willing to subject the patient for this procedure. And now, once they see the results, a lot of patients are being referred for this procedure. So, unless you have very good results, you cannot do the procedure. So, that is why, even though it looks very easy, not everybody does it, for one. As Madam said, we need a lot of backup. We need a neurology backup, we need a critical care backup, because immediately after surgery, BP can surge, go up and down. We need somebody to monitor the careful so that the patient doesn't land up in complications. Number one. Number two, about this patient in particular, yes, what he had was a type of TAA. TAA is of various kinds, as I told you. When the blood supply to the brain is reduced, not cut off, reduced, you get symptoms, TAA. And it depends on which part of the brain it's affected. Here, what he had was called global hyperperfusion. All 4 blood vessels were reduced. The whole brain was getting a low perfusion. So he was getting what we call a drop attack. He was getting like a fainting episode. So unless we increase the blood supply to the brain somehow, I may not be able to do it with all the 4 blood vessels. At least one blood vessel can take care of the brain. Of course, he's 93. Even though he's fit and well, obviously he's not going out to work and things like that. So we're going to keep him alive with good quality of life. And that is what we achieve.
Thank you, Doctor.
This is what I was addressing earlier. Worldwide, the acceptable risk factor is somewhere between 5 to 7%. 5 to 7%. Less than 1%. So we do far better than Western standards, mainly because we do this procedure routinely under local anesthesia. If you do it under general anesthesia, patient can develop stroke during the procedure itself, which we missed it completely. So, if we have a methodology of assessing the blood perfusion to the brain during the procedure, which we believe doing under local anesthesia is the best way, and that is what reduces our morbidity to a great deal.
Was the pandemic is disturbed more like the patient on the later stage with more complications?
Again, a very good question. This is a good example of how pandemic affected our specialty also, vascular surgery. If you come to my department now, all the patients have postponed their critical procedure. I'm not talking about routine procedure. Critical procedure by at least 4 to 6 months. Maybe due to so many reasons. One, they could not travel. 2, they lost somebody in their family, so they could not travel. 3, and they also economically drained out because somebody in the family had a COVID and all those things. So, by all these reasons, this is a good example because he got stuck in Bangalore. He could not come to Chennai during COVID times. So, COVID has affected every branch, including my branch.
So we see now.
During COVID, we started routinely giving anticoagulants to prevent thrombotic complications. For all the patients who had fever, except asymptomatic group, we started giving anticoagulations for all the patients and continued for another, again it's a debate, at least for about 3 months or so, we all continued anticoagulation to prevent further thrombosis. Even the patient was well, they all went home with anticoagulation to prevent thrombotic complications.
About the screening process, how much?
Message through that there is something called a procedure which can prevent stroke, but unless you recognize the symptom early and reach the doctor, you cannot do anything about it. So please don't ignore any symptoms if you have any. So that is one. Secondly, as far as screening program is concerned, as I told you, ultrasound Doppler is an excellent tool for picking up disease, without doing an angiogram and all those things. Like how they do an echocardiogram for the heart, you can do it and just was discussing with Madam, we have a technology where we can group in patients with high risk. Our AI can pick up which group of patients should undergo the screening program. Like if you put in, age, smoking, diabetes, hypertension, dyslipidemia, obviously you come at a high risk group. And if you can pull in these patients to undergo the screening program so that we can get them in early.